Autism is one of the disorders of development, and it has a high morbidity and really can affect the quality of life of a person who is affected by it if it's not managed properly. But it looks like there's a huge gap in knowledge, even among health workers. And so parents tend to send their children from one hospital to the other, and care givers or health workers are usually helpless as to what to do to help these children. And in Ghana, when a parent visits a hospital or about 3 or 4 hospitals and they don't get any help, they start to conclude that the condition cannot be cured or helped in any hospital. And so they resort to other means to get the condition cured. And some of these things that they do for these children actually go a long way to affect them negatively. And so it's important that we equip ourselves with the right kind of knowledge so that when they come to us, we'll be able to help them wherever we are. And there are very few neurodevelopmental pediatricians in the country. We can't say that if you are in Tamale, send your child to Dr. Marilyn in Accra, and whilst they are waiting to get ready for the visit, then we'll be there. We wouldn't be doing anything for them. So we need to know some basics. And so you are really welcome to this afternoon's program. So there'll be 2 presentations, one by a neurodevelopmental pediatrician, and then the other, the founder of Craft Foundation or Craft Education. They have been helping caregivers with children who have autism. And when it's time for him to speak, we will talk about applied behavior analysis, one of the recognized therapies that has been found to help children with autism. And I would entreat us all to mute our mics when we are not talking. There will be time for question and answers. So you can type in your question into the chat box and it will be read out and the questions will be answered. If you also want to speak, you can raise your hand and you'd unmute and talk after the 2 speakers have done with their presentation. So the first one will be given by Dr. Marilyn Mabel Wilson. She's the CEO of Mission Pediatrics. She's also the medical director there. She's a neurodevelopmental pediatrician, and she will talk to us about autism, the risk factors, the comorbidities, what we can do to help these children. So Dr. Mabel, if you can upload your slides.
I'm trying to share, but hosts
Rudolph
allowed me.
Yeah, I am working on that.
Okay,
it's done, so it should be available now.
Okay.
And I would also say, whilst Dr. Mabel is trying to upload her slides, there's a link that will be put up for parents who want to sign on to what Craft is doing for children with autism. There'll also be another link that seeks to bring health personnel who are interested in helping such children together so that we can help these children. So Dr. Mabel, please, you have the floor.
Okay, please give me a minute to do this Zoom thing. Can you see my slides?
Yes, it's visible.
Yes, we can see.
Okay. I'm trying to put it into slideshow. Just oh, okay, wait. Okay, I think I'm good to go. So good evening, everyone. You're welcome to this presentation. Oh, some of us, these dinosaurs, I'm trying to put on my video too, but now I'm lost. Okay, yeah, I found it. Okay. Okay, so as Gloria said, we will be talking about autism. And I know my target audience are health workers. So we'll go a bit technical. So as you all know, April is Autism Awareness Month, and 2nd April was Autism Awareness Day. And the whole point of autism, setting a month and a day for autism awareness, is to educate the public. So this is why we are doing this. So, okay, so we are talking about autism spectrum disorders. We will be looking, the scope of the presentation, we'll be looking at the causes, if there are any causes we can find, and risk factors. We'll look at clinical features and red flags. There's a bit of a difference. So red flags are maybe like signposts that may alert you that, oh, this may be autism, but not all red flags, or not every child who has a red flag will actually be diagnosed as having autism. We'll look at the diagnosis and differentials and comorbidities, and then also look at management. So we know that autism is a group of complex neurological and developmental disorders, and they cause atypical behavior. So now the way to go is to say atypical, neurotypical, atypical. We don't like saying normal and abnormal because it doesn't, I mean, it causes discrimination, and it doesn't sound really good in the parents' ears. So yes, it causes atypical behavior in, first of all, the social interaction and communication of the child. It also causes this child to have some repetitive behavior and restricted interest, or they are interested in very few things. It also causes some differences in their sensory perception, which means that the way they perceive the ordinary stimuli is either on the extreme side, either they need extra to get what you and I get, or they need just a little bit and then they are oversensitive. So they're either very undersensitive or hyposensitive or hypersensitive. And then all these things together should limit and impair everyday function. Apart from that, these symptoms should not be, there shouldn't be any other developmental condition that can account for the collection of these symptoms that the child presents. Okay, so that is what autism is. So let's look a bit at the etiology. So the first and the earliest diagnosis or documented diagnosis we know of autism was in a guy called Donald T, who is actually alive now. I recently watched a documentary about him. He's 80-something, somewhere in a small town in the US. But he was documented as having autism in 1938. And unfortunately, even though we've come a long way, in the beginning, it was a rough road. So when it comes to etiology, initially, it was thought that something called the refrigerator theory, which meant that mothers were not interacting or socially loving enough with their children, and that's why they got autism. And believe me or not, it was the medical field that purported this idea. And so it was like, okay, work on yourself as the mother, and if you're able to love your child properly, your child won't have autism. But fortunately, with research, we are now learning more and more about what autism is. And we do definitely know that it's a neurological condition. So it has a neurological etiology. We are not totally sure why or how, but some of the things that point us towards it is that MRI. So in research and as it keeps going, people are doing functional MRI. So not just regular MRIs, but functional MRIs. Lots of research has shown that the way the brain works in an individual with autism is very different from a neurotypical. So we know that neuropathological abnormalities on functional MRI. So it tells us there's something going on in the brain. We know that about a third of individuals on the spectrum will also have seizures, coexisting seizures or epilepsy. So that tells us that the etiology is in the brain. There have been some neuropathic studies, especially with zebrafish. So these are not human studies that have found differences in prenatal onset differences in the brain for these fish who then develop symptoms of autism. So we know that this is starting in the brain. Then, as at now, there are lots of genes that have been identified as giving increased susceptibility to autism. Up to about 100 of different genes have been studied. So we know that there's some genetic susceptibility to the etiology. So, I mean, we know that this is not a spiritual thing. We know it's in the brain. We know it's biological. We know there's some sort of genetic things going on, okay? So when it comes to the genes, some of the chromosomes that have been implicated are chromosomes 2, 3, 7, 15, 17, 22. And as I said, about 100 genes have clear ties to ASD. The commonest genetic cause for ASD is Fragile X. So up to 3% of individuals with autism will also have Fragile X syndrome. So we know from then that yes, things are happening with the genes. Apart from that, what makes us so sure that the etiology is genetic is that there's a concordance rate of classic autism in up to 60% of monozygotic twins and up to 92% for the broader phenotype, okay? And we know it's multifactorial. So even though we know this is the brain, we know this is the genes, we know that there is some elements of environmental, there's something about the environment sort of inciting the genes that make you susceptible to cause you to get autism. So let's look a bit more about the environmental factors, okay? So we know that while we know that there may be or there's a bit of environment going on, is that there's lack of 100% concordance when you study monozygotic twins who have autism. So the theory is that there's some kind of second hit trigger phenomenon. So you may have the genes make you susceptible, but maybe something else in the environment will then, hit you for you to get it. Because when we do studies for families, they may have the same gene susceptibility, but not every member of the family then has autism spectrum disorder. So we know that there's some environmental factors. The ones that have been studied and really known now include things like maternal rubella infection, CMV infection, giving sodium valproate to a mom who is pregnant, and now things like any form of fever is getting some association, even paracetamol, mothers taking paracetamol during pregnancy, there's been research, but remember, these are not like causative things. These are risk factors, and the research is still going on. There's been some research in perinatal events. So we know things like threatened abortion, advanced maternal and paternal age, and things like birth asphyxia and prematurity. All these things are risk factors, but basically we do not know the etiology. We are not 100% sure about the etiology. So this is what I've said. So when somebody says, what causes autism? It's multifactorial. We are not totally sure. We do know that there's lots of genes involved. There's lots of environmental factors, including now there's some research that is talking about air pollution, environmental pollution, toxins, everything. So there's a whole lot of things going on when it comes to the etiology. So maybe take home, it is multi-genetic, multifactorial, and majorly genetic with some environmental factors. Okay, so that is usually what I tell the parents. So let's look at some clinical features. So failure to respond to name, and this is really common in the how many years that I have been seeing kids with autism. This I can tell you is almost like 90% failure to respond to name. So these children can hear, they would have done a hearing test, but the first thing the parents know is that when you call him, he doesn't respond to his name. And we expect children to start responding to their name by 9 months. So 9 months, 12 months, when you say Kofi, they know their name, they will turn. It's not a hearing development, it's a social development. That when you're in a crowd and somebody mentions your name, the instinct is for you to look up and see who is it who is calling my name? What do they want with me? What can I do to respond? So failure to respond to name is one of the clinical features. Decreased eye contact or atypical eye contact. So what we call object focused. So usually you expect that when you're interacting with the child, they look at you several times. And we do not take notice of this, but they do actually look at you about 3-4 times in a minute when they are interacting with you. But these kids on the spectrum, if you're playing with them, they are really looking at the thing they are interested in. If they look at you sometimes, it's just for brief moments. They don't pay attention to you properly when you're talking to them. Unusual attachments to objects. So yes, so examples like kids who are really attached to empty water bottles, kids who love broomsticks, who love, so, and it doesn't have to be an unusual object, but the attachment should either be extra strong or the attachment or the object should be unusual. Indifference to parents, speech delay, which is the most common reason that parents would come to the hospital to seek help. If the child usually by 2.5 years, they are not saying anything, no single words, then the parents come. But we do expect that they should come even earlier. So by 18 months, we expect that a child is using about 10 words, minimum 10 words at 18 months. So if a child is not saying anything at 18 months, it's not even saying single words like mama, dada. And remember that we are looking at communicative words. So A, B, C, D, 1, 2, 3 are not communicative words. If a child is singing all the rhymes and saying their alphabets and their numbers, they are not communicating with mama what and mama no, there is a problem. You need to look into it. We do know that there's about 30% of them will have a regression in the second year of life. And why this is so, we are not sure. But about 30% of these children will be doing well. They are saying their bye-byes. They may even be saying words. And then in the second year of life, they regress, okay? Then there are definitely deficits in social relatedness or social interaction and just the inherent drive to connect with other people. There's a atypicality there. There's decrease when you look at their play like critically, you see that there's a decrease in pretend and imaginative play. So when you start playing as a child, like Diamond's 1 year, it's more of exploration. You put the toy in your mouth, you bang the toy, and that's okay. But by the time you get to 2 years, we expect that you're doing more functional play, you're starting to pretend play with other people. So if by 2-3 years you're still just banging toys or breaking toys or just putting toys in your mouth, then we know that there's something going on. They have decreased nonverbal communication. So nonverbal communication are the things like the pointing. So pointing to request, which is the proto-imperative, then pointing to share interest. Oh, I see something that is interesting. I know you can't get it for me. Maybe it's a bird. I don't want the bird, but I can see it. I think it's interesting. So I'm pointing at it so that you also take note of it and we share that experience. That is proto-declarative pointing. So pointing to request usually will come up by 14 months, sometimes earlier. And then pointing to share interest by 16 to 18 months is there. So if that is not there, then that's a problem. Joint attention, gaze monitoring, these are all nonverbal ways of communicating. Other features would include, they can be really hyper-focused, and it's very difficult to shift their focus when they are doing something. And sometimes that's why when you even call them, they seem to not mind you. If they are doing something, they're really hyper-focused on it. Poor social and emotional reciprocity is it's difficult to explain that, but when you engage them, it's not the same. It's so difficult to get into their world, and it's difficult for you to pull them into your world. That's what we call, we term by social and emotional reciprocity. I think I have to hurry up because my time is going. Poor theory of mind skills. Theory of mind skills means that by 4 years, usually, a child should understand that what I'm thinking in my mind or what I believe in my mind, I mean, the basic, is not the same for everybody. Okay, so that's theory of mind. Then, of course, they like things to be the same. They may have stereotyped or repetitive movements. So let's look at the red flag. So what I've talked about now are the clinical features. The red flags are some of the things that, points out to you that, this child, we need to investigate if this may be autism. So a child may have these symptoms, but they do not necessarily mean that they have autism. So things like hand flapping, toe walking. So these are some red flags. So, okay, let me take this one. This one is better. So things like echoing of words. So we call that echolalia. So repeating, you say, how are you? They say, how are you? Or you say something and they just repeat it like a recorder. And that's what they're saying. Or only eating certain foods, bruxism, grinding their teeth, lack of eye contact. These are all red flags. Some of the red flags, as you can see, are interchangeable with the clinical features. So I may not go through all the red flags. So eye contact is really important. How much are they looking at you? And parents will say, oh, he gives me eye contact. But then you want to, is the eye contact enough? How difficult? So the question I ask is, how difficult is it to get his attention? That's a better question, or that's a better way of assessing eye contact. When he's coming to you to get something, is he coming and he's just getting it? Or is he looking into your face, looking at you before he's doing the thing? When you're talking to him, is he looking at you, paying attention to you? So that's what eye contact is. We've talked about lack of response to name, lack of coordination of non-verbal with the verbal, lack of sharing interest, repetitive behaviors, like playing with only one kind of toy all the time, or unusual sensory exploration. So that kids who want to put everything in their mouth, or they want to smell everything, or they want to look at things from the corner of their eye like that, or peer at things. These are unusual sensory explorations. And things like impairments in communication, or so either delay in speech, delay in the non-verbals, lack of the pointing. Some of the kids who come and actually talking, they are saying they can do short requests, they can read, they can name objects, but you see that there's some atypical pattern to the way they speak. Some kids who may have not watched cartoons, but they are speaking like, you have to like, they're slanging, you can't even tell what they're saying, or they have this sing-song voice in the way they speak. We say that is unusual prosody. So all these things are red flags for autism. Emotional regulation. So you get something from them that they are playing with. Yes, every child will get upset and cry, but this child may, have a meltdown and scream for 1 hour crying because maybe a toy was taken from him or he was moved from the playground into the room. These kind of things. These are red flags. So what are the differentials? So differentials of autism spectrum. So it's not every child with red flag, as I said, who has autism. These are some of the things that we need to rule out, or that can present as autism or mask as autism. A child with just a language disorder or a language delay. Some kids with language disorders can be echolalic, as in they can repeat things. They can repeat things a lot. So you remember I said that echolalia, or repetition of things, is a red flag. But a child with language disorder can also repeat things. So you need to differentiate this. But a child with language disorder should have normal social communication or social interaction, and they shouldn't have repetitive behavior. A child who has global developmental delay or intellectual disability. If in moderate to severe intellectual disability, there is presence of stereotype behaviors. So these kids can do a lot of the motor stereotypies, the head banging, the rocking, the flapping, and it doesn't mean that they have autism. It's seen also in intellectual disability. Could this be a social deprivation? I've seen a couple of that. So kids who are in the orphanage, who are not held at all, are left in the court all the time, they don't develop properly when it comes to their social interaction and gaze and response to their name. Nobody calls them anything. So could that be it? Is this a sensory integration dysfunction? So we can have children who do not have autism, but just have, differences in their sensory integration. Because of that, they may behave like children who have autism. Is this Einstein syndrome? So Einstein syndrome was coined by an American economist, Thomas Sowell, and supported by another physician called Dr. Stephen Camerata. And these are children who have delayed speech, but also have really high IQs, and they are very good at analytical things. So they speak later on, like 5 years, 6 years, but they tend to be really gifted kids who are really brilliant. Is this Angelman syndrome? Is this Fragile X? Is this congenital rubella syndrome? All these things may masquerade as autism. So these are differentials you need to pull out. Is this early antisocial personality disorder? So antisocial personality disorder is diagnosed by the psychiatrist after 18 years. But yes, they don't just start at 18 years. When they're younger, there are certain things. So they may not want to mingle properly. They may be, antisocial. Those are some of the early features: playing alone, being by themselves. Then could this be a combination of things? I've seen kids who just have a language delay, they're a bit hyperactive, they're a bit sensory, but they do not actually meet criteria for ASD. Early anxiety, so children who are anxious or who have ADHD in their early years, 2 to 3 years, can present like that. Children who are hyperlexic, these are all differentials for autism spectrum disorder. So now let's go to diagnostic challenges or diagnosis. And there are some challenges. So unfortunately, we don't have a blood test that can just, we can just do the blood test and we know this is autism. This would have been so much easier if we could do that. And there is research going on. It's still in the experimental stages, using blood to, it's not to diagnose, but rather to give you a heads up that this child may have the genes or susceptibility to autism. But at the moment, we don't have a blood test for autism. So determining, getting a definite diagnosis can sometimes be a challenge. Also determining the child's overall functioning. So about 60% of children on the spectrum will actually have normal intelligence, but because they are not talking, because they're not paying attention, it's very difficult in the younger ones for us to say that, yes, this is autism with normal intelligence, or this is autism with intellectual disability. So just determining their overall level of function when the parents will ask you, so is my child going to have a normal life? Those kind of determination is really, really difficult. Then, of course, determining the etiology. As I said, it's a group of disorders with lots and lots of things going on when it comes to etiology. So some parents want to know what caused this. Determining that is also a challenge. So for diagnosis, the gold standard is using what we call the autism diagnostic interview. Now there's a revised version, so that's the newest one, the autism diagnostic interview revised, or the ADIR for short, together with what is called the autism diagnostic observation schedule. There are different other tests that you could use, but these two are said to be the gold standard. And so the first one is a really detailed, extensive interview that you give to the parents. The second one is more of a semi-structured play session with the child. And then once you've done that, you score the ADIR, you score the ADOS, and does it meet DSM-5 criteria before you can say, yes, this child has autism, or no, they do not have autism. We do not do laboratory investigations for every child. So as I said, it is guided laboratory investigation. So if a child has comorbidities like epilepsy, we may talk about the comorbidities later, but if there's epilepsy, if you think this is a syndrome, Fragile X, congenital rubella syndrome, if you think this child could have a metabolic disorder, is this lead toxicity, then you would want to, do some guided investigations. But the main diagnosis is, does this child fit criteria for DSM? That's what we do. Okay, so yes, some of the kids may need an MRI of the head. If they come and they have a macrocephaly, that means they have a big head or they have a small head, they have some focality in the CNS, then you'd want to do a brain MRI. If they're having seizures, definitely we want to do an EEG and possibly a brain MRI. If they have things like they regress when they get sick, or they get sick often, if they are slow, if they have gross motor delays, because critically speaking, ASD or autism shouldn't give you gross motor skills delay. So if they have all those things, then you may want to do a metabolic screen also for them. And then elsewhere now, everybody gets some genetics tests. So if it's a boy, you diagnosing for Fragile X, they will all get a Fragile XA. If it's a boy, you're investigating for ASD, they will all get at least a screen for Fragile X. And now there's the genomic hybridization or microarray, when they give you the whole array of genes, and then sometimes it becomes a problem. You don't even know how to interpret it. But we are not doing genetic testing now in Ghana. The Metropolis Lab offers it. They take it to India. And so far, I think only a couple of people have asked for it, but it's so expensive that most people eventually don't even do it. But hopefully we'll get to the day where we can do genetic testing for everybody, because that then will help us to know more about the disease. So this is the DSM-5 criteria. It's really small here, but I just put it there. You can Google DSM-5 criteria for autism spectrum disorder and take a critical look at it. So there are 4 sections, A, B, C, and D. You need to meet the 3 criteria under A. You need to have all 3. You need to have 2 out of the 4 at least in the section B, and you need to fulfill the section C and also section D. Okay, so let's talk about some of the screening tools that are available. So the MCHAT, the modified checklist for autism revised, is available. It's very easy to use. It's free. You can get it over the internet. And it's advised that all children by the age of 18 years or 24 months, 18 months or 24 months at least, should have a screening for ASD, for autism, through their regular pediatric or health supervision visits or health baby child visits. They should have a screen. And so you can use any of these screens. The most frequently used will be the MCHAT. The ASQ, which is the Ages and Stages questionnaire, is also available. It's also free. You can get it. But the other things like the autism behavior checklist, the childhood autism rating scale, and the rest, that can be used for screening and also used as adjuncts for diagnosis. So let's talk about comorbidities. So autism spectrum comes together with other things. So there's a high rate of epilepsy, as I said. 30% will also have seizures. They can have developmental delay. So up to 50% will also have intellectual disability. But some can be also very gifted with very high IQs. They always have sensory issues, so sensory integration issues. They have issues with auditory processing. As they grow older, they always have emotional regulation issues, so depression. They may have ADHD, either inattentive type or the hyperactive combined type. They can have specific learning difficulties also, dyslexia, dyscalculia, non-verbal learning disorder. They can be very brilliant, but they seem to have uneven learning styles. So they may be doing very good in maths, but when it comes to the languages, they are failing. So they have really uneven intelligence and learning styles. So let's talk about the treatment. Well, Rudolph is going to go into details, into details with ABA, but it's one of the most research and evidence-based treatments that we have. Applied behavioral analysis. Okay. The other treatments or therapies, but basically all the ones I've written here, developmental, individual difference, relationship-based, pivotal response training, they all surround a communication kind of therapy. So communication or speech therapy with a behavior therapy. Okay, so remember the definition I gave of the fact that these individuals have deficits in their social interaction, in their communication, and then in their behavior. So all these different treatments using different methods are trying to tackle these 3 things. So that's basically what the treatment is about. We do not have medication for it, and we do not have a cure, but we know that these treatments like the speech therapy, behavior therapy, ABA, cognitive behavior therapy by psychologists for those who are high function, who are verbal, high functioning with good intelligence, they do well with CBT, social skills intervention, sensory integration therapy that will be done by the occupational therapist, special education, in the classroom, it's a multidisciplinary approach to treatment. If you've seen an individual with autism, you've seen just one individual. They look and they are very different, even though they still have these core deficits that are used for that gives them the diagnosis. But therapy usually will be individually based. Okay. So let's talk about medication. As I said, we do not have medication that will take the autism away, but we have medications for the comorbidities, okay, for the comorbidities. So ADHD, so impulsivity, inattention, motor hyperactivity, is very common in children and individuals with autism. And the medications that are used for ADHD, unfortunately, are not very effective in individuals with ADHD, with autism also. But yes, you can have a child who meets criteria for ASD, autism, and also meets criteria for ADHD. So then we use stimulants. But the caveat here is that they don't do as well compared to the children who have only ADHD. So in the country now, the stimulants that are available are Ritalin and then Concerta, which are stimulants medications that can be used for children who have ADHD. So if you have a child who has autism and also has frank ADHD, you could try that. They can also have lots of anxiety. And remember that when children have anxiety, it doesn't present like adult anxiety. Anxiety in a child can actually present like hyperactivity, and they are just on edge. It's like they are on a high alert all the time. So, you know, they are always all over the place. They are emotionally dysregulated, everything. That could be anxiety. And lots of the kids who have sensory issues are also really highly anxious. Then you could have OCD, which is obsessive compulsive disorder. OCD tendencies are already somehow part of autism, but you can actually have a comorbidity of that. And so we would use SSRIs. The common ones would be fluoxetine, sertraline. Fluoxetine is FDA approved for children for anxiety for OCD. So you could try that. Unfortunately, the lowest dose we have available is a 20 milligram, and I think it comes in a capsule. So for the young ones, sometimes it's difficult to give. Then aggression. So aggression is one of the issues that you may have to deal with. Aggression. So aggression, usually we use atypical neuroleptics, and sometimes in combination with mood stabilizers. So the atypical neuroleptics are usually, the most common will be the risperidone. But there are times when I've used aripiprazole and Abilify, sometimes quetiapine, Seroquel, depending on how severe it is. A combination of risperidone and Tegretol also sometimes works quite well, not in every child. There are a few kids who've done very well on clonidine, which is an alpha agonist, initially for hypertension, but its byproduct is that it actually helps with aggression. So sometimes some of the kids have done well with clonidine or guanfacine, which is the long-acting type. Self-injurious behavior. So these are the kids who are really, hurting themselves by head banging, chewing on their wrists, on their fingers, pulling out their hair. Most of the times, aggression, self-injurious behaviors would be seen in children who also have severe intellectual disability. Not exclusively, but it's more common. So for self-injurious behaviors, we treat with the same medications like that of aggression. So the atypical neuroleptics, mood stabilizers, clonidine, or a combination of them. Sleep is a really big issue in children with autism. So some of them just can't go to sleep, or they go to sleep in short bits. They get up in the middle of the night, or their sleep is turned all over. They are asleep during the day, and in the night they are awake and they are making noise. Neighbors are, being disturbed and everything. Sometimes we use melatonin for them. The most important though is that, children in generally and everybody in generally does well with routine, but especially kids on the spectrum, they do very well with routine. So there should be a bedtime routine. I mean, first thing, does this child have a bedtime? It's not okay for him to watch TV till he feels sleepy for him to sleep. No. So depending on his age, how much sleep does he need? When is he supposed to wake up? We decide what his bedtime is. 20 minutes before bedtime, there's a small routine. If it's bath time, we read a book, we have a massage, we do some play game, whatever it is. And then we all go and lie in the bed, put off the lights. Whether you sleep or not, we are on the bed. That is the routine. If you do this consistently, just this week, one of the families came and said they did this for they've had this sleep issue with their daughter forever. They started a sleep routine, and within 2 weeks, she's sleeping. So it really helps and it really works. And then, of course, reduction of screen time. If they are addicted to the iPad, they shouldn't be watching iPad 2 hours before bedtime, because the lights behind the screen and things affects the melatonin in the brain, and it doesn't help them to sleep. Constipation is also one big one. Constipation. So for treating constipation, and this is not even only in children with autism spectrum, but for the kids who are non-verbal, if they have constipation, if you're backed up, you don't feel fine. And so they get really antsy, they are more irritable. So treating constipation is very, very important. It's always important to ask if this child may have signs of constipation. So of course, for constipation therapy, you want to treat by changing their diet, making sure they have enough fiber in their diets, they are well hydrated, drinking enough water, they are getting enough exercises. Usually that is not a problem because they are always moving about. And then of course, if it is chronic functional constipation, sometimes you need to, clean them out, use lactulose or PEG 3350 and clean them out. And sometimes they have to be on these fiber supplements or lactulose for like 6 months to make sure that they are, they are regular before you stop it. Then of course, seizures. For seizures, it's known that there are 2 peaks in children on the spectrum, the toddler peak and the adolescent peak. So the 30% who are going to have seizures may either have it in the toddler period or in the adolescent period. So we use the regular anti-epileptic medications. The only thing is that sodium valproate has the side effects of hyperactivity. Phenobarbital also has the side effects of hyperactivity. Levetiracetam, Keppra, also has side effects of behavior issues like aggression and maladaptive behaviors. So, it's the devil and deep blue sea. You have to bear in mind some of these side effects, and depending on what kind of seizure the child has, you make your best choice out of it. So I'm almost done now. So the search for etiology, a cause, a cure is still ongoing. Research in different things like is this immune dysfunction? There's been a lot of research in the immunity, the gut immunity in children on the spectrum. What is fever during pregnancy? How is this related to autism? Is there some GIT inflammation going on? Is this autoimmunity? So there's lots of research. We hope that we will find a cause and we'll find a cure soon. Then a few myths, or one particular myth. So autism and vaccines, and that has been, it's been there from long. But we do know, and CDC has it on their websites, that yes, vaccines do not cause autism. So vaccines do not cause autism. We know that for a fact. And there's some studies that have, in fact, there are lots and lots of studies that have come up. This was one done by CDC and a couple of people. They compared 256 children on the spectrum to 752 controls. And they looked at, they were looking at their antigen load through vaccination, and there was no correlation with autism and vaccination. The largest study now was one done recently in Denmark, where they looked at almost 600,000 plus. It was a nationwide study in Denmark. It's over 600,000 children, and they're looking at that compared to and the risk of having autism if you are taking the MMR vaccination. So looking at this group of children, those who had not taken the vaccine, those who had taken it, there was no statistical difference amongst them. So we know that vaccines do not cause autism. So what's the prognosis? Even though there's no cure, we know there's treatment, and early intervention is key. The early we get them, the better. I mean, we can diagnose them as early as 18 months, even younger. So it is very important for us to diagnose them. They need to have early intervention. They need to have consistent therapy. Rudolph will talk to you about that. Some 25 to 40 hours of therapy in a week is considered ideal. 10% of children may have optimal outcome, which means that after intensive therapy, they come back and you assess them and they don't meet criteria. We don't say we've cured them. We say they've had optimal outcome. Majority will need support for the rest of their lives. 20% of individuals with autism are gainfully employed. It could be more, but very few of them are gainfully employed, and we need to work towards that. This year, the theme is inclusion in the workplace. How can we do more to get individuals who are on the spectrum but capable in the workplace? So normal cognitive abilities improve with early intervention. This research has shown us, and early intervention helps with good prognosis. So to conclude, we know that autism spectrum disorder is basically a disorder of social communication. The etiology is largely unknown, but we do know it is multi-gene susceptibility with some environmental factors. We've talked about the clinical features. Diagnosis is mainly by history, examination, observation. Sometimes we may need to do some laboratory investigations for the comorbidities, but early intervention is definitely the key. Thank you very much. Gloria.
Hello, Dr. Marvel. Thank you so much. I enjoyed it so much. I just refuse to look at the time. I think our audience also have learned a lot. So one very important thing I picked was that a lot of them come with delay in speech, and that's something we as healthcare professionals should look out for. And then the screening tools. I have used the MChat. It's quite easy to use. I think we should all make it a point to use it so that we pick some of these kids early. Please type your questions into the chat box. After the second presenter is done, we'll read them out and you'd have your answers. We've also put up 2 links in the chat box. One is for parents who have children they would want to with autism, and they would want to sign on to what Craft Education is doing. The other one is also for healthcare professionals who also want to work with Craft Education to help children who have autism. So thank you very much. The next speaker is Mr. Rudolph Ampofo. He's the founder of Craft Education. They've been doing so much to help children and parents who have children with autism. He will speak about applied behavior analysis, and then he'd also talk about what they do at crafts. So Mr. Rudolph Ampofo, you have the floor.
Thank you so much, Gloria. The way you said Mr. Rudolph Ampoff, I was like, you, Rudolph will be fine.
It's making you look too old, eh?
I'm very young, and apparently I couldn't apply to Achimota, so I hope the group here can accept me. Great. So thank you so much for the presentation, Dr. Mabel. Indeed, you did touch on a number of the things I am going to talk about. So you've actually made my work easier, and it was really great just listening to all the amazing insights that you gave to us today. Just let me know if my screen is up. Do you see my screen?
No, not yet.
No.
Okay, let me just fix that and see if this would work. How about now?
There was a start, like you started screen
It's
sharing,
not
but
so-
I
it's
still can't see anything.
Trying
Is it? Huh.
No.
Okay, I'm going to try one more time, and then hopefully technology doesn't let us down. This. Do you see my screen now?
No. No.
Rudolph, it says
Yeah.
you are viewing Rudolph's screen, but it's blank. So I don't know if you want to sort of start sharing, like going through your slides to see if we'll see it or not.
Yeah, do you see my slides now?
No, we can't see that.
Okay, let me just let me sort this out. Just a second. The technology that we are relying on is trying to let. So let me quickly.
Okay, so I think whilst Rudolph is trying to get his screen set up, we can read out a few questions. Dr. Mabel, I have a question for you, actually a couple. So the first question is that there are people who talk about gluten-free, casein-free diets for children who have autism, and that it's improved, it helps to improve their behavior and generally some of the comorbidities, also allergies and other things. I don't know if there's any science behind that, and if in your experience you've also seen children do well when the casein and then gluten were taken off their diet.
Yeah, so okay, the short answer, this one is very a controversial issue. So the short answer is that the research hasn't shown us that the diets are treatments or even cures, okay? But yes, children on the spectrum are children in general. So some will definitely have casein allergies and will have gluten allergies. What I've seen or what I advise is that, yes, if you believe that your child may have an allergy, and sometimes I actually let them test for it, then it is okay to do the trial. I've seen a few kids who tested and they were not allergic, but the parents swore that when they take those things out, they help. But since we are not offering a cure, I say just do an honest trial and see, but be a bit scientific about it in the sense that see what do you want to see improve. Do it for 3-6 months, and if it is improving, why not? You can continue. Some have said they've seen improvements, others did and they didn't see improvement. So that's the answer I can give you for that one.
Okay. And I'm happy you mentioned autism and then vaccination. A lot of parents are also very worried about vaccination causing
Yeah.
autism. So I'm very happy that you touched on it. There was a question in the chat box from Mami
Rudolph, I
Araba.
hope you are sharing your screen and take off as soon as you are ready.
Yes, I think he's been having some challenges, but he'll be back in a bit.
Okay.
Uh-huh.
Okay.
So let's take the question. Yes.
Okay.
Mami Araba is saying, are there early cues in diagnosing autism in babies?
So when you're saying babies, you mean like newborns?
I'm sure maybe infants or
Yeah.
up to 6 months.
So the red flags that I talked about, the eye contact, the reciprocity and everything may not be very obvious, be in infants less than a year. So the earliest I have diagnosed a child with autism was 11 months. And the parents had seen the symptoms or the red flags from about 9 months. So far, that's the earliest I can say, 9 months to 1 year. Yes, definitely the red flags will be there. Some, of course, will be later before the 18 months. But below 9 months, I can say it may be difficult. There's some research where they're looking at children on the spectrum and they are looking at their siblings because, as we said, multi-genetic, there's a higher incidence in siblings. And they look at them, and this is research-based, and they could pick it as early as 6 months. But that is in research. So they were looking at, it was a simulated computer eye contact things to see how much they were looking at humans and objects. But that we can't do at 6 months. It will be difficult. But definitely between 9 months and 12 months, if there's something there, we should be able to pick it up.
Pick it up. Okay. Thank you very much. I think there are more. There are 2 more questions in the chat box. Gillian is asking if autism worsens with age. I've heard somebody say that, oh, if it's autism, they'll get worse. I mean, when a child has had delay in speech and then they weren't sure whether it's autism or not, and then somebody said, oh, if it's autism, they are likely to get worse. If it's just expressive language disorder, they will get better. So does it get worse with age?
Well, I mean, it gets worse if you don't treat it.
Do anything.
Yeah, if you don't do anything about it, it can't get worse. But I mean, it also depends on the severity. If you have a child who is a level 1, who has really is on the spectrum, but it's mild, just by the mere fact that they are amongst other children, they may get a little better. They don't lose their autism, but they will get a little better. But generally, if you do not do something about it, it will get worse.
Okay.
Yeah.
There's another one on paracetamol possibly causing autism in children. I think Dr. Mabel talked about that briefly.
Yeah, it's an association. We don't. It's not a cause like a direct causation.
Okay. And then TA is also asking if autism can be diagnosed later in life. If no, does it mean adults recently diagnosed went unnoticed during their childhood?
Yeah, so from the definition I gave, and if you look at the DSM, it says that the symptoms should have started when they were young. So below the ages of 3 years, the symptoms should have started then. But it is possible that you wouldn't have seen it till the social demands became severe. Okay, so yes, I've diagnosed somebody who is like, I think the oldest I've diagnosed so far is 27. And this was, I mean, university graduates doing masters. Yeah, so
Wow.
it was there. And with the history, it was definitely there. It's just that it wasn't picked as autism. Yeah.
Okay. So Emilia is also asking, are there any nutritional needs or challenges associated with autism spectrum disorder?
Nutritional challenges, yes, they can be picky eaters. You remember the picture of the red flags? We said they could be picky eaters. So if they're picky eaters, and they may eat very selected few things because either from sensory issues, then there may be nutritional challenges. There is no specific diet for autism. That what we've discussed already.
Okay. And then somebody is asking if there's a clinic in Ghana where children can be referred to. So Nakita, Dr. Marilyn Marbell is at Mission Pediatrics, that's in Accra. In Kumasi, Konfanochi, there is a neurodevelopmental clinic there. There's a neurologist, Dr. Hammond is there, and there are also other there are psychiatrists there who also attend to children who have autism, but they are quite few, very few specialized people who take care of these children with autism, and I think that's why
Dr.
Edem too
Children's
is
Hospital.
yes PML,
Yeah.
and then Dr. Badu is also at
Dr. Badu at
Kolebu also.
Dr. Yvonne Brew at Greater Regional Hospital, Greater Accra Regional Hospital.
Regional Hospital. Okay.
And then Dr. Erica at 37.
Okay.
She's
so these are
psychologist.
places that, yes, children with autism can go and get help. We are hoping that very soon they'll be spread all over Ghana so that people do not have to travel all the way from the north to come to the south. So Rudolph, please, if you are back on, you can upload your slides. I'll read the last question and then you take over. Tia is asking, so this means we are all autistic, but of varying severity then?
No, why? that means I didn't do this thing properly.
So Rudolph, TA was the one who asked if it can be diagnosed later in life. I'm sure he's thinking a lot of those we call antisocial probably may be walking around with autism, but I don't know, Dr. Mabel, you may have to.
So you remember the definition I said no matter what, I mean, those things, there's a set criteria, and those criteria, the last one is such that it should be impairing function. That is it should be impairing function. Okay, so TA said not in a bad way. Yeah. So I mean, Hans Asperger, one of the big wigs in autism, says that you need a little bit of autism to be good at certain things, to be good in accounting, banking, science, data, that kind of thing. So yeah, a little bit of autism is nice. It's okay.
Angela's hand is up. Angela, please ask your question. Rudolph, we still can't see your slide, unfortunately.
Hello, thank you so much, Gloria, for giving me the opportunity to speak. And thank you so much, Dr. Marvel, for the presentation. It's been great. I was just typing my question when you called me out. So my question is about mental chelation. Some parents, especially those who have read a lot about the autism, can be very obsessed with trying to get mental chelation for their children because they have heard that it might actually help with some. I don't know. My question is that I also have seen a few studies that have mentioned that it can be harmful too for some children, depending on the people that you end up doing that therapy for. So my question is that, do you have much experience with doing mental chelation therapy in Ghana here? And is there any way of picking which children to test for heavy metals? Like, is there anything we can do to be able to identify who is at risk of the heavy metals to actually go ahead and test and offer that therapy if it's going to be helpful for that child? Thank you.
Okay, thank you, Angela. So mental chelation is not part of the recommended treatments that I put up or everyday evidence-based treatments. Mental chelation, no. So when it comes to mental chelation, dice therapy, we are going more of the biomedical route. And even for the biomedical routes, if you did a test to look for mental toxicity, they would use more of nutrition and supplementation to treat it, the metal, if it is high copper or whatever. But proper metal chelation where they do IVs and put in all those things, no, it is not advised. It's actually harmful. Those are one of the things that both CDC, WHO will tell you that it's a no-no.
Thank you very much.
Okay.
Yeah, Dr. Mabel, I have shared a link to my slide. So can you attempt to share yours
Okay.
if you were successful?
Okay, you've shared it on the chat.
Yes. So if you can just click on the link.
Okay.
Just jump in there.
Okay. Is that the teletherapy webinar?
Yes.
Okay. Okay. Okay, now I have to share it, right?
Yes.
Now, me too, I'm looking for my sharing thing. But I think
so,
you have.
Rudolph, maybe you can start while
Yeah.
Dr. Marvel is trying to.
Have you enabled me to share
to
now?
upload your slides?
Yes, you can share it on Zoom.
I can share it on Zoom.
Yeah, so if you
Okay.
share your screen, then everyone can follow as well.
Okay.
Yes. So just to reiterate something that Dr. Marble said, early identification and intervention is critical when we are talking about young children with autism spectrum and related social communication delays. The main reason is that the earlier they are able to start some form of intervention, the better. We have some medical research indicating that even before um, even before you know,
Please, can
diagnosis.
you see it?
Yes. So if you can
Okay.
just
Yes.
So if you can just click on next, it will
Okay.
just go to the next one.
Okay.
Yes. 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 So one of the things that have been said is that emphasis on early identification and referral for treatment, even if a diagnosis of autism is suspected but not yet confirmed, is essential because with social communication delays and autism spectrum, the idea is that there are some behavioral deficits that could be addressed with some therapy. Once a diagnosis is confirmed, it basically tells us what it was, right? But it doesn't really stop us from continuing with all the progress that we could have made, or the gains that we could have made with the kids once we started suspecting something. So it doesn't necessarily mean that it's a bad thing. It just means that you are taking the steps to making sure that your child or children with the condition are getting the care they need earlier than later. So just to talk a bit more about autism spectrum treatment, it's generally, we normally think of it within the concepts of comprehensive treatment. So these are a variety of treatment procedures that are customized to fit the needs of a child. So like Dr. Mabel said, when you meet one child with autism, you have met one child with autism. So when it comes to treatment, every single treatment approach is different. So if there are a million kids with autism around in Ghana, there are a million approaches to their treatment. So, and that's what makes it, creates a lot of the complexities with behavioral therapy and the expense that is associated with it. And similar to what was said again, it needs to be intensive. On average, about 30 hours per week for 2 or more years will be ideal. But then when you start thinking of it within the concept of hourly cost and things like that, then it starts to get monumental in itself. Next slide, please. So one of the things that we like to focus on and is applied behavior analysis, because as mentioned, it's one of the most well-researched approaches to behavior therapy. And it's really based on learning and science, the science of learning and behavior. So it enables the therapist to in situation that would ensure that they are fundamental that needs to be asked when it comes to children. Now, with behavior analysis, ABA, we hello.
Yes, Rudolph, we can hear you.
Sorry, my lights went out. Sorry about that. So just to pick up from where I left off. So when we are looking at applied behavior analysis, we are essentially looking at three main things. We are looking at understanding the behavior we see. We are looking at understanding the environmental impact on the behavior. So when I say environmental impact, I'm not talking about, I'm talking, yes, everything around it. So if it's in the house, every single thing that is happening within the house that is influencing or impacting the behavior. And we are also looking to understand when learning takes place. It's very important. And as we move along throughout the presentation, you get to understand how all these things are connected. Next slide, please. Now, within the scope of applied behavior analysis, focus use of the functional assessments in the ABC model. Now, the ABC model, which stands for antecedent behavior consequence, is implemented to direct or change specific behaviors by noting what triggers the behaviors. Now, in the previous slide, I did talk about understanding the impact of the environment and also understanding the behavior. So really the ABC model enables us to really understand the various triggers of behavior. So you might have a child who all of a sudden bursts out crying. You have no idea where it's coming from. You are shocked to death, but trust me, there is a trigger within the environment that is causing that behavior to happen. So what behavior therapy or ABA tries to do is understand the triggers and then puts in interventions or measures to address those triggers, those behaviors. Now, like I mentioned, the ABC model stands for antecedent, behavior, and consequence. Now, with the antecedent, all we are trying to say is we want to understand why the behavior is happening. Sometimes you, as a health worker or as a caregiver, one of the very first things you might encounter is the behavior itself. It's fine, but you always need to put your mind to why is this behavior happening? What is causing the child to behave the way they are behaving? Now, once you understand the why, you can now adjust your reactions to that behavior, which we call the consequence. So with caregivers or parents who might not understand what is going on with their kids, they might leave the child to cry. And that builds and reinforces a certain behavior for that child. And so by doing nothing, you are not helping the child. Sometimes some parents might not understand, and so they might implement some discipline. They will associate behaviors with discipline and vice versa. So it becomes very distorted and you might not get the desired behavior you want. So with behavior therapy, you get to understand why behavior is happening, understand the behavior itself and the reactions to those, what reactions you need to put in place to ensure that you are getting the right behavior set. Okay, great. So as I was saying, with behavior therapy, one of the biggest things or one of the fundamental things when you are thinking about behavior analysis is reinforcement. These reinforcers serve as motivators. It's really integral throughout the treatment program. And they are the consequences of behavior that make sure that the behavior happens over and over again. So for instance, you might identify that your child or a child likes to play with their tablets, but the child has challenges sitting down properly. So really you are using the tablet as a reinforcer to ensuring that they are learning how to sit down. So it's basically, you can think of it as baiting the child, come and sit down or sit down. They will sit down and then you reward them with a tablet. So having reinforcers always helps. Now, when I mentioned that you identify that the child likes a tablet, it means that that is the preferred consequence. So we are always looking at doing what we call a preference assessment to evaluate what kinds of things children like. Now, the reason why we do preference assessment on a regular is to ensure that the children are not getting tired of the reinforcers. So assuming they are playing with the tablet all the time, they get used to the tablet and they are not motivated by the tablet to come and sit down. So having rotating through reinforcers help to maintain the attention of kids during treatment programs. Now, within the scope of everything, the ideal situation is going to a specialist center. So you could visit Dr. Mabel's place. I think they do have some behavior therapy services there. You could go to some of the therapy centers you are aware of, Awawa too, and everything like that. But then you realize that there are some, challenges there, right? So it's always good to evaluate your options. Next slide, please. And the truth of the matter is it's hard. I was almost tricked to saying it's easy. It's not easy. It's really hard raising a child with autism or related disorder in Ghana and in Africa. They are 10 times less likely to go to school. And the time lag between observation and diagnosis is 7 years on average. And so you realize that the questions are, why are these things happening as often? You have some people living far away in the north, and we are telling them to drive all the way to Accra, all the way to Kumasi to get access to care. That really delays the time they get access to care. Now, very few people in Ghana actually have access to behavior therapy. Now, when you think about it within the larger scope of therapy services, for every one therapist, there are about 12,000 children available. And the minimum cost of getting some basic care, some basic number of hours, about $7,500 now a year. Now, when you think about that within the scope of a continent where, the people earn as low as $1.90 or $160 a year, then it's really difficult to comprehend how they will be able to afford some of these services. Now, and I'm sorry to be prophet of doom. Hopefully, I can become, I can try to be the savior at some point in time. But when you look at the situation in Africa, you realize that there are about 26 million people who are estimated to have autism or a related disorder. Now, when you think about it within the scope of other continents, it's 36% more prevalent in Africa as compared to the US and Europe. And with 42% between the zeros of 0 to 14. However, when you look at Ghana and Africa, the services available are very, very little, almost non-existent. If not for individuals like Dr. Marbell, Awawa, too, and some of the centers that are really providing some basic care. It's unimaginable to think that we'd have one therapist to 12,000 children. Even teachers suffer when they say, well, I have 57 children in my classroom. That becomes really difficult to comprehend. So the question we have been doing is what has been our response to some of these numbers, right? And if you can go to the next slide. So what we at Craft Education decided to do was to pull ourselves together. Luckily, we have been working in the field for quite some time, and we have colleagues who've been working with technologies that are very effective when you think about it within the scope of Ghana and Africa. So what we decided to do was to build a teletherapy service that uses parent-mediated interventions to deliver behavior therapy in the home or school. And the way we are doing this, we've built a chatbot that coaches parents and teachers of young children with behavioral delays to deliver behavior therapy through instructional videos and weekly phone calls. Now, one of the things that make our service quite different is that we have spent time to create simple instructional videos, about 1 minute, 30 seconds, will give you a good idea of how to implement an activity or how to do an activity, for instance. So if you want to teach a child how to sit down, there is a 1 minute, 30-second video that explains that. Now, we understand that that is not the catch-all, right? So what we've also done is we've made available weekly phone-in therapy sessions with certified therapists. Now, these individuals have conversations with the caregivers, either the parent, someone who is, who can understand, things. And then what we do is we provide the training to them to deliver the therapy. And there's on-demand support through text messaging and other messaging applications. So if they want to understand the principle, but they've forgotten, they can easily text it and find the information. And so that's generally what we've done with our platform. So this has enabled us simplify the ways families in Africa access care. So within a few steps, they can actually move from observation or concern to getting an assessment, a behavioral assessment done. Now, I just want to put a disclaimer out there that it's not a formal diagnosis, but it's an assessment to help us identify some behavior challenges that may exist in children. If it doesn't exist, this is really great news. But if it exists, what we do is we work with the caregiver or the one who visited our platform to come up with a plan and then train them on how they can intervene. So this training happens over a period of time with the hope that they will be able to understand certain concepts. So what we do is we break it down to layman terms and then deliver those lessons. We believe that everyone has the ability to learn. Everyone here on the call, the 105 people who've been in and out of this session have the ability to deliver some form of therapy. The question has always been, how do we do it within the scope of all the things we have to do? And so what we have been trying to do is build a sustainable model that will require not so much of your time, but if you are able to give enough, some time, 30 minutes, 60 minutes, it's very difficult to fathom that a caregiver might not have 30 minutes or 60 minutes with their children. So within that time, what ways can you engage that child meaningfully to help them build the relevant skills? And that's what we've been doing. And that supervision piece is coming from certified therapists who review the cases, review the data or the information that caregivers are given, and then put it back in that intervention program by working on approaches with the caregivers. So you realize that that whole plan, intervention, supervision loop is a partnership between caregivers or users of our platform and certified therapists we've been able to build internally. So at the end of the day, we are not limited by the four corners of the world. And with the growth in technology and people accessing mobile internet, it makes it quite easier to deliver a model through this. Next slide, please. Now, we like to believe that we are shortening the pathway to accessing behavior therapy. Now, based on the research, and we've connected all the sources, but if you need any additional sources, we'll be happy to share that with you. But what we like to believe is that we are shortening the pathway to accessing behavior care. So when you think about it, on average, initial parent consent heightens at 2 years, as Dr. Marvel indicated. Ideally, coming in earlier would be the best, scenario. But when parents start to compare their kids with other kids, they start to realize that something is a bit off. Now, at this point, we are able to identify behavior deficits. Now, what we hope is that with partnerships with healthcare workers, we'll be able to even identify earlier if they are referred to our platform earlier. Now, by the age of 3, so we don't stop there. By the age of 3, they would have been engaged in about a year's worth of ongoing behavior interventions. Now, when you think of it within the scope of 30 minutes each day by 365 days, you are looking at a large number of hours, which can help the child achieve some behavioral growth or still achieve some skills. Now, when you look at, so the parts in the gray tell you what is currently happening on average. And the parts in the blue tells you what craft education is doing throughout the period where the initial parent consent and where they actually visit a hospital or a diagnostician happens, right? So all throughout the ages of 2 all the way through to 5, we are actually working. And when you think of it, that the average age at which someone will visit a hospital is 6, average age which they will engage a therapy center is 7, and the average age, the mean age which they will engage a diagnostician is 8, then these things start to scare you. So what we've always worked towards is, how do we build a pathway that is providing some level of care at each step of the way, at each age point, where some level of behavior training is administered. It might not be 30 hours, the ideal 30 hours, but if it's even an hour a day or an hour a week, it all boils down to something. Little drops of water make a mighty ocean. And so with some of those thinking, we decided to build the platform we built. Next slide, please. Now, with that, what can happen is caregivers can actually deliver about 20 hours a month of therapy. With the one-on-one model where a therapist is having a weekly pulse, we've been able to expand it such that, complementing with the videos, the on-demand learning, a therapist can handle 240 individuals. Now, some people might say this is extremely ambitious, but we've actually spent about 1.5 years testing different models, testing different times. We started out saying, okay, let's give everyone 45 minutes to have a call. 45 minutes is really a long time if it's not a webinar. And to keep a caregiver on the phone for 45 minutes, it just didn't work. So we kept the time and realized that we needed to include videos and on-demand learning, where a chatbot made it easier to deliver session learning based on where caregivers were. So when we realized that the bot can realize where there are certain deficits and then deliver the learning so that they are continuously learning. And even with just a simple registration or subscription, every day a lesson is delivered so that caregivers are always engaged with the lesson and encouraged to submit a report, encouraged to ask questions. They can have live chats with therapists. So at no point in time are you alone within your therapy journey, your behavioral journey. Now, with this, we are able to reduce, the time which, people get care by 70%, where it would take them about up to 6 years to get care. At the age of 2, we are actually engaging with a therapist, just that it's being led by the parents. Next slide, please. Now, what we've noticed is that with the little drops that we keep on talking about, we've seen improved behavior in some of the caregivers who are using the platform. We've continuously worked at making it easy to understand some of the things that we are discussing with caregivers. And this has improved some of the communication and social interaction that children have at home, where with one of the cases, the child would not sit down even if your life depended on it. After 3 months of working with us, we realized that they could get a child to sit down for a longer period of time to interact with something. And now we worked with the caregiver to transfer that skill of sitting down quietly to other instances. So now they'll go out to church and the child will sit down quietly when they are told, sit down, and it works. And what we've also identified is that it creates equal opportunity for everyone out there to access some level of behavior therapy. With the work that we've been able to deliver 84 sessions between our caregivers. We've provided about 277 minutes of training, about 33,000 minutes, more than 3,000 minutes of therapy delivered by caregivers, and about 100 hours of supervision over the last 3 to 6 months since we started working on this. Now, as I went through the presentation, I mentioned parent-mediated interventions. Now, the question has one of the things we had to grapple with was why parent-mediated interventions. For us, it was potentially a cost-effective strategy to increase access to evidence-based autism spectrum intervention, in the sense that every caregiver is the one who initiates the initial contact with the specialist. We also believe that educators and even healthcare workers are, first point of contact for kids with autism and related social communication delays. So what if we included as part of our search, looking within ourselves? What if we did that? We are capable of teaching. We know we don't have autism spectrum in a sense, as someone was asking, but we are conscious enough to deliver some kind of teaching. And the first teachers in every child's life is their parents. I mean, whether you slice it, dice it, the parent figure in a child's life is the first teacher. So building the capacity of teachers is the way to go for us, because when you think about it within the scope of distance to certified therapists, you're looking at some 80,000 people in Ghana who are not actually accessing care at all. When you look at it within the larger scope of numbers, right? Between the ages of 0 to 14. So why don't we build those capacities to deliver some form of therapy at home? Next slide, please. Now, so far, we have been talking. What we try to do is we always try to talk to our caregivers as well. Some of them see that it's gradual. It's not as quick as they want it. Caregivers always want to see results yesterday. We always want to see results yesterday, even as we want to see results yesterday. But unfortunately, we need to work towards those results. So yesterday is not a possibility for us, but today, tomorrow, and the day after are possibilities. And so with our caregivers, they've been able to start seeing improvements in their, in the lives of their kids. They feel more in tune with their kids. They feel more confident. They understand that when they don't understand their particular behavior or they have particular concerns, there is someone who they can reach out to without having to think about how much they'll pay for transport or how much fuel they'll buy, how long it will take them to get to where they need to get to, and how long it will take for them to wait. And even worse for working parents, they now need to think about at what time do I close from work and make it to the center and pick up my child. So for them, it's basically a really good alternative. However, we do recommend having some level of center-based therapy. But as we think of it within the larger scope of things where there's limited access, this is a really interesting alternative. One of the parents said that I actually like the phone calls. So the phone calls really helps build relationships with caregivers, and they're able to ask questions, then they get the message in and share their observations. So those are some of the feedback we've gotten from parents. Now, our hope is that we'll be able to work towards working with healthcare workers, because we see healthcare workers as at the center of the issue. When, based on the surveys we did, when a parent recognizes that there's something off, one of the first places they go to is the hospital. And when they encounter the healthcare worker, the question is, even if you know what to do, after you do it, then what? So we want to be the then what of healthcare workers. If it means that if you are not comfortable doing a diagnosis, still refer us, because we've identified that early intervention goes a long way. If you're a healthcare worker and you're looking to set up a therapy center or a clinical within your health facility, you can leverage on our platform to really do this, because at the end of the day, you have the trained specialists to guide whoever you have within your center to deliver the therapy. So we manage the data, we manage the programming, and then we show you on how to do the implementation. That is how my mother and I really got into behavior therapy when we started our therapy center in Kumasi about 4 or 5 years ago. You can also refer caregivers to therapy when you need to, right? Or you can join the care community so that we can actually refer cases to you for diagnosis, and vice versa. So there are a lot of ways that we can work together. There might be some medical related questions that caregivers might have. We might not have the answers, but you will. So really building this community around us and moving beyond this initial step and saying that we've heard these things, we know these things, we understand the difficulties parents are facing. Let's move a step further to really providing some form of care or improving that pathway. And we need to start working on those things. Next slide, please. So our team is 4 people, but we have other people at the back who are helping us deliver the therapy. But generally, there's me, I do strategy, product partnerships. There's Ifwa, who is focused on the technology. Akil, who helped me put together these slides. I couldn't have put it together if you put a gun to my head. He's really the brains behind the work that we are doing. So he leads clinical operations and behavior therapy. And we have Nakita Natala, who helps us, does an amazing job with, giving us the right information, research, and helping us think through things in terms of tweaking the product. So we don't just build, but we build based on research. We build based on what users are experiencing, and we build based on within the context of Africa. So we are always trying to ensure that we are building something that works and fits the market. And next slide, please. So really, all that we are trying to do is giving children the quality of life they deserve. Data, capability, collaboration equals better quality of life. Thank you so much for spending your evening with us and being here. If you need to reach out, these slides will be shared. The video is being recorded and it will be shared as well. So we'll definitely keep in touch. And if you haven't seen the links, just register in the links. If you're a healthcare worker, there's a link for you so that we can have your details. If you're a caregiver and you want to start, an assessment and start exploring some of the care services we have, you can also register by clicking on the link below. Thank you.
Thank you very much, Udo. Thank you. And now we know you can still access care without having to travel all the way to Accra or Kumasi. So thank you very much for what you are doing for children. We can take a few questions, maybe 2 or 3, and then we'll wrap up. If you see some of the questions also in the chat box, you can read and then answer. I went off a bit, so I lost a couple of things on the chat box. So if you see any question addressed to you, Mr. Mabel or you can answer. You can also raise your hand if you want to ask your question. So does you see any question in the chat box directed to you?
Not at the moment. Yes, and the video will be posted on the Healthy Kids Foundation Facebook page, and on Dr. Mab will be also provided to Dr. Mabel, who will be able to also post it on her social media channels, and we would also do same for those who were not able to join or those who want to rewatch the videos. And we would also make our slides available for anyone who wants to have a look at them as well. But if you have any questions, we would love to take them, either for Dr. Mabel, for myself, or just a general discussion that you want to have. Kindly just the floor is open for I guess stakeholders within the space who are looking to make a difference. So it's great to always chat about things.
And I also put the link on the various pages, health pages, Pediatric Society, another platform. So I'm sure if you are not able to get the link here, or it's not working for you, you can access it after the program. And somebody is asking on this slide. I don't know what you do, but some other level. But the recording will be shared. So
yes, the recording will be shared, and I'll also send an email to the participants with the slides. So all the participants will get the slides as well.
Okay. Please, can you hear me? Am I audible? Somebody please, can you hear me?
It's difficult to hear you.
All right. So thank you very much, everyone, for coming. We really are grateful
with us, and we believe that you've learned a lot and you'd help the children that come to you to access care. Let's remember that early intervention improves the outcome. Is very, very important. Let's make use of the screening charts, the M charts, the others that Dr. Mabel talked about. They are quite easy to use. Let's not look so helpless now that we have been equipped with information, and we also know where to refer these children to if we feel we need extra help. So I have seen people, yes, it's just the presentations they are commending you on. So Dr. Mabel Olsen and Rudolph, thank you very much for making time to also speak to. I will say that in the absence of any other question, I would wish you all a very good evening, and thank you once again for joining us. Thank you.
Thank you for having us.
Thank you. All right. Goodbye, everyone.
Bye.
Thank you.
Bye.
Bye.
Thank you.